Good evening if you are in Abu Dhabi, and good afternoon if you're in the UK. My name is Amir Sam. I'm an endocrinologist and head of the School of Medicine at Imperial College London. And it's my pleasure to welcome you to our third masterclass in this series in 2024, which aims to bring you updates in clinical endocrinology and the underpinning science. And today we have two fantastic speakers who are clinicians but also great educators in the School of Medicine at Imperial College London, and they're going to talk to us about bone and calcium disorders. We have had masterclasses in adrenal and reproductive endocrinology that have been recorded and are available if you want to go back and listen to them. It is my pleasure to welcome Professor Alex Comninos, who's a consultant endocrinologist at Imperial College London, and he leads the endocrine bone unit at Imperial College Healthcare and also academic tutoring in the School of Medicine. And he's going to talk to us about bone health in hypogonadal younger women.
Good afternoon and good evening, and thank you, Professor Sam, and everyone at ICLDC for this very kind invitation to speak to you this afternoon. So I've been asked to talk to you about bone health in hypogonadal younger women. My interests include reproduction, bones, and behavior, and so hopefully you will gain some insight. So why is this topic important? Well, essentially, a woman who fractures before the age of 50 has a vastly increased risk of fracturing after the age of 50. And obviously, we want to avoid fractures because they carry high morbidity and mortality. So when during life is bone health important? Well, here is a graph of bone mineral density against age, and you can see as we grow in height, our bone mineral density increases. Once we stop growing in height, it then fills in, and so we reach a peak bone mass around the age of 30, both in men and women. It's important to reach the best peak bone mass possible. This is under the influence of several hormones and minerals such as PTH, IGF-1, calcium, and the sex steroids. And the reason we want to achieve the best peak bone mass is because there's going to be inevitably a drop thereafter, especially during the menopause in women. So, although the large amount of bone mineral density is genetically determined, all conditions throughout life will influence bone health, including hypogonadism. So let's link the reproductive axis with bone. So I'm sure you're aware of the importance of the sex steroids on bone, but don't forget other upstream hormones. For example, prolactin has negative effects on skeletal homeostasis, partly through its suppression of the reproductive axis, so the generation of hypogonadism, but also through the prolactin receptor expressed on osteoblasts. So high prolactin levels can actually directly reduce osteoblast function. And I'll talk to you a bit later on about kisspeptin's positive effects on bone. But the main hormone is undoubtedly estrogen in hypogonadal young women in terms of its influence on bone. So in the healthy state, estrogen affects the osteocytes, the osteoblasts that build bone, B for building, osteoblasts, and the osteoclasts that resorb bone. And the preference is for osteoblast activity over osteoclast activity. However, what happens when there's estrogen deficiency? Well, here we have a vastly increased activation of bone remodeling. You will see that in your clinical practice with an elevation in bone turnover markers. There is a slight decrease in bone formation and a very large increase in bone resorption. And importantly, this imbalance can be more severe in younger amenorrheic women than after natural menopause, often because there are other things going on in these younger amenorrheic women that will make this imbalance even more severe. So I'd like to structure this as the key practical challenges that you face in your clinical practice dealing with hypogonadal women, younger women, and their bone health. So firstly, we'll talk about the diagnosis, then the when and how of the assessment of bone health, choosing the best hormonal therapy, and deciding on the need for additional bone treatment. So starting with the diagnosis of the hypogonadal disorder. So the main ones really to think about are functional hypothalamic amenorrhea, congenital hypogonadotrophic hypogonadism, premature ovarian insufficiency, hyperprolactinemia, and surgery or medication-related hypogonadism. So here you can see a table that I've made with the main causes of hypogonadism in a younger woman, and you really want to get the correct diagnosis from the onset. Because in FHA, you may start with a period of addressing the underlying factors to see if you can get restoration of the reproductive axis. In POI, you really want to get in there early with estrogen. In CHH, you do want to get in there with estrogen, but maybe titrate the doses slowly. In hyperprolactinemia, you'll probably go with dopamine agonists to start with, and surgery medication related has other angles to cover. So in terms of differentiating factors, obviously FHA, you've often got enough evidence based on the history. In POI, the key really is that high FSH and LH. In CHH, there's often primary amenorrhea, and there may be some other clues like anosmia in the Kalman version. In hyperprolactinemia, obviously the main clue here is your vastly raised prolactin level. And in surgery medication related hypogonadism, the key is often in the history. So question 2, when and how to assess bone health. So let's start with when. So typically we assess bone health after 6 months of untreated hypogonadism. However, we may assess it earlier if there's an additional risk factor for poor bone health. This may be a severe nutritional deficiency or an energy deficient state, a history of fragility fractures, a family history of osteoporosis, or additional secondary causes of low bone mineral density. For example, diabetes will multiply your risk of fracture by 6. Other diseases we commonly see in the clinic are celiac disease and medication-related osteoporosis. You also want to assess bone health, obviously, before starting treatment, and then during the monitoring of that treatment, and typically within 5 years of your first assessment. How would you assess bone health in these hypogonadal young women? Well, you obviously want to know about the duration and the cause, get the diagnosis right, as I mentioned before, of that hypogonadism. You want to know if there's a history of fractures, and specifically fragility fractures. So these are falls from standing height or less. You want to know about a family history, medications, and lifestyle. And of course, you want to explore for other risks and other secondary causes of low bone density that can be addressed. And there is a long list of these. There can be endocrine diseases, gastrointestinal diseases, I mentioned celiac, for example, hematological diseases, rheumatological diseases, and various other connective tissue diseases. And so you want to address these additional risk factors as well. It's not good just treating with estrogen for the hypogonadism when they've also got celiac. You've got to look for everything possible before you embark on your treatment plan. In terms of the investigations, we do a full secondary causes screen, for example, celiac antibodies, and obviously we will assess bone mineral density, typically by DEXA. So firstly, how safe is a DEXA scan? Well, the answer is very safe. It's very low radiation. It's equivalent to 3 hours of natural background radiation. So me flying to Abu Dhabi would be about equivalent to 2 DEXA scans. And as you can see here, CT chest is 2 years of background radiation. An X-ray of the spine, which we often do as well in the clinic, is actually 6 months of radiation. So the message here is DEXA scans are very low radiation, so you can reassure patients regarding that. Another question I frequently get asked is when should we use T-scores and Z-scores, and especially in premenopausal women? Well, the consensus is that T-scores are designed for postmenopausal women, and they compare the bone mineral density to a young, healthy female reference, so to that peak bone mass around the age of 30. So T-scores are for postmenopausal women. Z-scores are the best tool to use for premenopausal women, and they are age, sex, and ethnicity match, and they're essentially like a reference range. So just as your sodium is between 133 to 146, 2 standard deviations each side of a mean, this is a 2 standard deviations each side of a mean reference range, and would make sense as the way to assess and quantify and diagnose low bone density. So if you see a Z-score of less than or equal to -2, you can say that patient has low bone mineral density for age, sex, and ethnicity. And that would then make you search for any underlying causes and then subsequently treat, potentially. Now, what about assessing for the risk of fracture? It's always useful to show a patient numbers in terms of what is my actual risk of fracturing. So I'm sure you're aware of Frax. It's an online tool, and essentially you can fill in the age, the weight, the height, their history of fracture, and various other risk factors, and you put in their bone mineral density, the femoral neck, don't forget, and you'll come up with their major osteoporotic fracture risk and hip fracture risk. Major osteoporotic basically means the forearm, the humerus, the spine, and the hips, okay? It doesn't include other bones. So their risk in this case is 41-year-old woman with Z scores, which are equivalent to T scores at this age, of about -3.2, has a major osteoporotic risk of 20% in the next 10 years, okay? And you can see, you then click on this NOG guidance for the UK, and it will place into the treat. You'll see this X here. This is for major osteoporotic, and this is for the hip fracture. And this will give you some idea. There are downsides to Frax. It's not fully accurate in some cases. For example, it ignores the number and the type of fractures. It also ignores the dose effects of certain risk factors, for example, the dose of steroids, and it ignores other associated diseases, for example, anorexia and the nutritional deficits and hypogonadism. But will give you a starting point. And this is often useful to show a patient in clinic to convince them of the need for treatment. So let's now move on to choosing estrogen therapy. Here I'm going to focus really on FHA, POI, and CHH, and I will suggest the optimal therapies in each case and show you the evidence for this. Obviously, in all 3 cases, the patients should be on adequate calcium, so at least 700 milligrams, really aiming for about 1,000 if possible, and vitamin D intake through diet with or without supplements. So starting with FHA, let's do a clinical vignette. So here you have a 41-year-old woman. She's referred to your endocrine clinic with a DEXA scan showing low bone mineral density for age, sex, and ethnicity in both the spine and the hips. She's had anorexia with secondary amenorrhea for 6 years, very low BMI. She's under long-term psychiatric care, but there's been no real improvement over the last 18 months. She's not sexually active. She's had no fractures, and there's no other relevant personal or family history. So what is the optimal hormonal regime to address low bone density? Is it the combined oral contraceptive pill? Is it oral or transdermal HRT? Or what about the progesterone-only pill or implant? Now, we'll come back to this clinical vignette shortly, but just something to think about. So, in functional hypothalamic amenorrhea, the 3 main underlying etiologies are this chronic starvation, it's the intensive exercise with low energy availability, or psychological stress. And these cause a plethora of hormonal and metabolic changes, and they can all impact on bone. So you've got this decreased kisspeptin signaling, the decreased estrogen, IGF-1, androgens, free thyroid hormones. You've also got raised cortisol, raised adrenaline, noradrenaline, many endocrine and metabolic changes as a result of FHA. And these all have net negative effects on the bone. So FHA is not purely a hypogonadal disorder in terms of bone. There's lots of other changes that will contribute to the low bone density seen in FHA, multiple mechanisms. So what is the evidence of this negative impact that I've shown you in principle on bone? So here is a graph of aerial bone mineral density Z scores in the spine, the total hip, and the whole body less the head in FHA participants versus healthy controls. And you can see in all three assessments, there is a significantly lower bone mineral density, look up to minus 1.4 Z scores lower. What you can also appreciate is that the longer the duration of the amenorrhea, so that's the 12 months or more is the black and less than 12 months here, you can see the longer the duration of the amenorrhea, the worse the defect. And also you can appreciate that in exercise-induced FHA, so that's the light gray, the lightest, the third column, the defect is less. And that's thought to be due to the protective effects of exercise on bone. So anorexia-associated amenorrhea results in a more severe bone impairment than exercise-induced. And a longer duration of this amenorrhea results in more severe bone impairments. Now, does this low bone mineral density that I just showed you translate into increased fracture risk? Obviously, yes, it does. There's a vastly increased fracture risk. We also see a lot of patients in clinic who are ballet dancers and former ballet dancers, and they have a very high reported stress fracture incidence. And importantly, this elevated fracture risk persists even despite remission from the FHA as far as 40 years down the line. That's because they don't reach that best peak bone mass frequently. So, as you know, the optimal treatment is restoration of normal physiology, be it through weight gain, decreased exercise and decreased stress. And with that, you get restoration of menses, and all this combines to improved health, and this includes bone health. But as you very well know, this is not always possible. So when should you consider starting estrogen therapy? Well, this is the graph I showed you just a few slides earlier. And do appreciate that the bone mineral density drops are seen with even less than 12 months of amenorrhea. Significant drops, even 1 Z score, as you can see here at the spine. And so most guidelines therefore suggest that if reasonable attempts to modify the underlying etiology and variables are not successful, then consider estrogen therapy after 6 to 12 months. Now, what estrogen therapy are you going to choose? So let's look at the evidence for each. Starting with transdermal HRT versus the oral contraceptive pill in terms of bone mineral density. So this is an important study. This is an open label randomized control trial. It looked at bone density over the course of about 12 months. And it was actually quite small, an N group of 22 to 26. And this was in normal weight oligoamenorrheic athletes, so exercise-induced FHA. Here they compared transdermal HRT to the oral contraceptive pill. So what did they find? So here's the change in 12 months on either of those therapies. So the patch, which is the transdermal, and the pill, the crossbars here, which is the oral contraceptive pill. And you can see at the lumbar spine, femoral neck, and total hip, there are improvements in bone mineral density, significant improvements with the patch, and much greater improvements than with the pill. In fact, with the pill, there's reduction in hip bone mineral density. So this suggests, and I hope you agree, that transdermal HRT is preferable to the oral contraceptive pill for bone mineral density. They followed this up with a subsequent study where they also looked at parameters of bone microarchitecture and strength, and showed again that there is improvements with transdermal HRT above those seen with OCP, especially in cortical thickness and trabecular area and cortical area. So up until now, we can say transdermal HRT is preferable to the OCP for bone mineral density, bone microarchitecture, and bone strength. And you may then be asking, why is this? Well, we know that IGF-1 is an important osteoanabolic hormone, and IGF-1 is important to bone and FHA, and this is highlighted by IGF-1 changes correlating with the osteoanabolic bone marker P1NP and resultant bone mineral density. And now I can tell you that the OCP suppresses IGF-1 much more than transdermal estrogen, in fact, by up to 30%. So here is a study, 12 months of OCP or transdermal estradiol, and you can see the decreases in IGF-1, and here it's represented graphically. Now, it's not just the route that's important, but also the form. So ethinyl estradiol containing estrogen preparations are thought to have more detrimental effects compared to conjugated estradiol and estradiol valerate. Okay, and also the dose, the higher dose of ethinyl estradiol in this case is more suppressive on IGF-1. So in summary, the route, form, and dose of estrogen suppress IGF-1 differently. So let's just list the reasons why transdermal HRT may be more effective for bones. So as I've shown you just now, transdermal HRT does not suppress the IGF-1 or its bioavailability. This is because it doesn't go through the first pass metabolism. However, there are other reasons. Transdermal estrogen does not increase SHBG, unlike oral estrogens, which can vastly increase SHBG. So there's more bioavailable estrogen when given transdermally. HRT regimes also provide daily estrogen, whereas there are estrogen off days, typically sometimes up to a week with the oral contraceptive pill. So there's more continuous estrogen exposure with an HRT regime. And as I mentioned before, ethinyl estradiol, as found in the oral contraceptive pill, or at least most of them, may have more negative effects on bone than other forms of estrogen. So based on the current data that I've showed you, transdermal HRT is preferable in women with FHA. But if there's contraception required, you could add in the coil. If they are insistent on an oral form of HRT, it's probably preferable to go for oral HRT over the oral combined contraceptive pill. And if oral contraceptive is required, then perhaps choose one with a natural form of estrogen, such as oral estradiol valerate. And I think there are two currently available preparations. In future, we will need more data on the best route, especially comparing transdermal to oral HRT, the best form, the best dose, progestins, and we also need better long-term data. These are short studies that I presented to you. So I hope you'll agree that transdermal HRT is probably the best option for this lady. There are other treatments available and listed here in this table in a recent review. So estrogen will improve things. If you add in IGF-1, there may be some more improvements, but obviously IGF-1 is not a standardly available treatment. The data with androgens is inconsistent. Leptin does have improvements on bone, but also there is a drop in weight, so that's not ideal. And there are concerns about denosumab and bisphosphonates and their use in young women of reproductive age, given their longer half-lives and ability to cross the placenta. There is also some data on the benefits of teriparatide in women with FHA, which is encouraging. What about emerging treatments? Well, kisspeptin receptor is strongly expressed on osteoblasts and osteoclasts, interestingly. And we've shown that kisspeptin administration can increase osteoblastic activity with increases in bone formation. And we've shown in vitro also that kisspeptin can decrease bone resorption by up to 53%, similar to something like the zoledronate in vitro. So the potential there for kisspeptin as a clinical treatment for low bone mineral density. And we've shown previously that kisspeptin can restore LH pulsatility and reproductive function in some of these women. So there's possibilities for a dual benefit of kisspeptin in women with FHA on their menstrual function and directly on their bone. So now moving on to POI. So again, as you know, there's a drop in bone mineral density following diagnosis of POI, and this translates to a large increase in fracture risk. The studies so far, so this is one of the main ones, an open label RCT, again quite short, 12 months, comparing transdermal to oral contraceptive pill, like the first study I showed you in FHA. And again, there's a preference, there's a benefit for transdermal compared to the oral contraceptive pill. And this can be partly explained due to the fact that transdermals seem to have better effects on the osteoanabolic pathways shown by this increase in P1NP compared to the OCP. So you can see transdermal HRT is preferable to the oral contraceptive pill in POI according to this data. What about oral HRT? So we showed transdermal in the previous one. Now oral HRT compared to the OCP. Again, oral HRT wins. And you can see that's the green line here in this lumbar spine BMD over the course of 2 years. Improvements for the green line. If you don't do anything, it's the blue line which drops off. If you give the OCP, no real change. What about giving a higher dose of oral HRT? So standard dose will be oral 2 milligrams, for example. If you give 4 milligrams, there's no real difference. Both of these, so that's the dark black line and the dotted line just below it. There's no real difference. There's no real benefit to giving very large doses of HRT. So in summary, oral and transdermal HRT are preferable to the oral contraceptive pill, and 2 is similar to 4 milligrams. Important to start early. Again, similar to an FHA, we need more data on the best route. Hopefully the POISE trial will give us some answers regarding that first question. The form, dose, and progestins, because different progestins are used in all these different preparations, and progesterone does have effects on bones. We're going to get more data in future. Finally, CHH. So interestingly, there are several genes that are implicated in CHH, of the about 30 or so, that actually have direct bone effects. That's something to be aware of. Now, the key really in CHH is optimal hormonal replacement before adulthood, because you want to achieve that PBM, that peak bone mass, as high as possible. And this graph here just is a graph of age against percent of maximal velocity, and basically shows, if you look at the blue line, that the peak gain in bone mineral is around the age of 12 to 12 and a half. And that basically underpins the reason why it's so important to get optimal hormone replacement before adulthood. And there are several regimes that can be used here. In adulthood, we know that if you don't give hormonal replacement in CHH, the Z scores are much lower, and this can translate to an increase in fracture risk. So the recommendations are for DEXAs, baseline DEXA at final height, and then repeat that DEXA after 2 years of treatment initiation in adulthood. In terms of treatment, it's transdermal or oral HRT rather than the OCP, as it's more physiological and also based on the studies that I've showed you before in FHA and POI. And obviously you want to start early, the treatment, as you may fail to fully restore if you start your treatment late. So finally, deciding on additional bone treatment. So when might you need to do this? Well, the patient may prefer not to take hormonal therapy. The patient may have a contraindication to estrogen treatment. Or what about in the patient who's failing to respond in a bone perspective to the estrogen treatment? This can be defined as bone mineral density that is dropping, typically more than 5% in a couple of years. If they have 2 or more fragility fractures, you may consider also that this may be treatment failure. And also, what about additional bone treatments when you transition the patients off estrogen, for example, at 10 years post the mean menopausal age? There are options here. You've got your anti-resorptives, bisphosphonates, denosumab. There's some evidence for raloxifene, for example, alongside the use of GnRH agonists in various hormone-dependent cancers, and anabolics such as teriparatide and romosozumab. Generally, my advice would be talk to your local bone specialist if you're considering these, because there are some implications. Some have longer half-lives, some cross the placenta, some are very costly, etc. And so it's very important to involve your local bone specialist if you're going to transition or add additional bone treatments. So this takes me to the end of my talk. So we talked about the diagnosis of the hypogonadal disorder, the key differentiating factors, and the importance of getting diagnosis right from the beginning. We talked about the when and how to assess bone health, so 6 months after amenorrhea or earlier if there is additional risk factors. We talked about using Z scores in these women. how to calculate their fracture risk or give an approximation at least, selecting the best estrogen treatment. So in FHA, it's transdermal HRT. In POI CHH, it's transdermal HRT, but you probably can use oral because they have a less suppressed, or they don't have a suppressed IGF-1, and the importance of starting early. And we talked about deciding on additional bone treatments, and monitoring the response would really be things like asking about fractures, changes in height, assessing their bone turnover markers, and their bone mineral density. So I hope you found that useful. If you want to listen to me talking about some other topics, you can also refer to the osteoblast box set available on the Imperial Centre for Endocrinology website by clicking there. Thank you very much.
Thank you ever so much, Alex. That was a superb talk. We'll just take a couple of very quick questions. You mentioned prolactin may have a direct effect on the osteoblasts. So in a patient who's got a mildly elevated prolactin, but no other symptoms, classically we wouldn't start them. Do you think that's a new indication for starting treatment?
Yeah, that's a very good point, and I wouldn't say it's a new indication. It's a new indication for assessing bone health. So, you know, in someone who's had a chronically raised prolactin, don't ask me how long, but maybe 6 months or more, you may want to assess bone health. And if you identify additional risk factors, you may proceed to doing a DEXA scan.
Thank you. And there's a question about a premenopausal woman who's had a fracture. T-score or Z-score?
T-score. So yeah, T-score. So T-scores are for postmenopausal women, and they are for men over the age of 50. Otherwise, you should use Z-scores.
But this was a premenopausal with a fracture.
Yes, a premenopausal woman. Yes. So you should use Z-scores. Sorry.
Okay, so you meant Z-score for
yes. So you should use Z-scores. In a young woman, they are equivalent, to be honest, because they are in that Z-score range. So the Zs and Ts are very similar at young ages.
Fantastic. Thank you so much. And then final question, any data on tibolone in these patients?
Yes. So tibolone is known to have beneficial effects on patients. And we know, as we know, tibolone can be used in some circumstances where HRT may not be ideal. So that's another option as well. Correct.
Thank you very much, Professor Comninos. I think in the interest of time, we need to move on to our second speaker, Dr. Preeshila Behary, who's a consultant endocrinologist, joining us from the Charing Cross site.
Good afternoon, everyone, and thank you, Professor Sam, for this introduction and for this opportunity today to talk about the effect of bariatric surgery on bone health. So in the UK, the two most commonly performed bariatric procedures are the Roux-en-Y gastric bypass and the sleeve gastrectomy. But from 2018 onwards, the sleeve gastrectomy has actually overtaken Roux-en-Y gastric bypass in popularity, and that's really in keeping the global trend as well. So both procedures, so Roux-en-Y and the sleeve, both produce superior weight loss compared to even the latest anti-obesity medications such as tirzepatide and semaglutide. So for this talk, I will focus on the Roux-en-Y and the sleeve gastrectomy only. So as you're all aware, in the SOS study, the Roux-en-Y gastric bypass showed sustained weight loss for over 20 years, and both the sleeve and the Roux-en-Y gastrectomy showed sustained reduction in glycemia up to 5 years compared to best medical therapy. But what about bone health? Should we be concerned? So we all know that there's significant weight loss after bariatric surgery. Weight loss can also lead to mechanical offloading of the skeleton. And its most extreme form, for example, when astronauts are in space, they can actually lose up to 2% of their bone mineral density in a month. And if you contrast that to postmenopausal women on Earth who lose only 1% of their bone mineral density in a year. So there's a big difference, and that's due to mechanical offloading. So what tends to happen is mechanical offloading tend to stimulate your osteocyte. Now, your osteocyte are your main mechanosensors in the bone, and that leads to an increased release of sclerostin. and sclerostin has inhibitory effect on your osteoblast, hence causing bone loss. So bariatric surgery is also associated with malabsorption of nutrients. And we are aware that vitamin D deficiency is already quite common in the obesity population, and this tends to be exacerbated after surgery. Calcium tends to be mainly absorbed from the proximal gut, and after RYGB, the gut is essentially bypassed, leading to an impaired calcium absorption. Also, there's also reduced gastric acid production after the RYGB, hence again impairing calcium absorption. So these will lead to secondary hyperparathyroidism, which is actually very common in the bariatric population. Up to 50% has been described in the literature. And this will obviously lead to increased bone turnover, contributing to bone loss. What about the gut hormones? So it's fairly well established that postprandial level of GLP-1 and PYY go up several fold after both ROY and the sleeve gastrectomy. There's also been report of GIP and ghrelin going down after ROY gastric bypass. Now, those hormones have receptors on osteoblast and osteoclast, and they do have a mixed effect on the bones. For example, GIP has a positive effect on the bone. So in healthy volunteers receiving GIP infusion, an inhibition in bone resorption is observed. Ghrelin has also positive effect on the bone. So in rodents, it tends to stimulate bone formation, and that's mainly via action on growth hormones level. PYY, on the other hand, has negative effect on the bone and has been shown to reduce bone mass in mice. GLP-1 has been shown to have positive effect on the bone in animal studies and in vitro, but more of a neutral effect in human studies. For example, in a study where they used liraglutide in type 2 diabetic patient, a very limited effect on the bone turnover markers or BMD was found, although the authors argued that despite the weight loss that is normally seen with GLP-1 analog, there is neutral effect on the bone mineral density, which suggests that there is a positive effect on the bone. So in summary, there are various potential mechanisms by which bariatric surgery can negatively impact the bones. So what I would like to do is to use a case to try to explore further what those changes on the bones are. So this was a 33-year-old man who was referred to our clinic a few years ago with low bone mineral density. He suffered from severe brittle asthma. He was on biologic, and he also had sleep apnea and prediabetes. His BMI was 37.7, and his risk factors for low bone mineral density included a vegan diet. He was on steroid inhalers. He had previous high doses of oral steroid. He also had a maternal history of osteoporosis, but without any fragility fractures. So his DEXA scan showed a Z-score of -3.1 at the spine, which is, as Professor Comninos explained earlier on, very low for his chronological age, and a normal Z-score at the hip. So his biochemistry showed a lowish vitamin D level, raised PTH, and a reduced 24-hour calcium urine excretion, which would be in keeping with a reduced dietary calcium intake. So we managed him with replacing his calcium, so add Cal D3, replacing his vitamin D, and offering some lifestyle advice as well. He came back to clinic though, saying he wanted to lose more weight and that he's been referred to the weight center for consideration of ROY gastric bypass. So at this point, I would like to ask the audience what they would do. And these are your options. So nothing different, just continue at Cal D3 and cholecalciferol. Would you counsel him against having bariatric surgery? Would you recommend a sleeve gastrectomy over ROY? Or would you actually start him on IV zoledronate prior to ROY gastric bypass to prevent further bone loss?
Here we go.
Here we go. Oh, okay. So it's quite fairly split, but it looks like starting on IV zoledronate is a bit more popular. So quite a few people went for option A and B. So For these people, I suppose the question here is, what is the actual risk to bone health with OYGP or bariatric surgery in general? So let's have a look. So this was a study where the authors followed up patients after row-wide gastric bypass for 5 years. And they measured the spine and the hip BMD, both with a DEXA scan and a QCT, to measure the volumetric BMD as well. And as you can see here, there was quite significant drop in the BMD at the spine, about 7% up to 5 years. At the femoral neck, down to 15% at 5 years, and at the total hip as well, down to about 15% at 5 years. So there seemed to be more of an acute drop over the first 2 years since the operation, and with a more gradual, slower drop between year 2 to year 5. And the same finding was also found with volumetric BMD as well. Important to note that in this study, all the participants had adequate calcium and vitamin D intake as well. So we cannot really blame insufficient calcium or vitamin D for the changes on bone density that we can see here. The authors also went on to look at the bone microarchitecture. So bone microarchitecture is a very important determinant of quality of bone, hence bone strength as well. And what they use is the HRPQCT, which is the machine that I've actually shown here on the right. And that look at the bone microarchitecture of the radius and the tibia. And what they found is there was increased cortical porosity at 5 years after OYGB at the radius and tibia. So this is the increased gray shading, and also a deterioration in the trabecular bone as well, with a decrease in trabecular number and an increase in trabecular separation. Next, they look at bone turnover markers. So just to remind you that P1NP is a marker of bone formation and CTX is a marker of bone resorption. And what they found is significant increase in both CTX and P1NP after surgery, which is maintained after 5 years after surgery. And CTX tend to be increased more so than P1NP, as you can see here, up to 200% increase, whereas P1NP increased up to 60%. And these are findings that has been found in other studies as well. And in some studies, they also found that CTX can be elevated as early as day 10 post-row-wide gastric bypass. This is really before any significant weight loss has actually happened, and tend to peak about 1 year after surgery and have been shown to remain elevated for several years after surgery. So I've shown you the changes in BMD, bone microarchitecture, and the bone turnover markers, but does that translate to fracture risk? So in this study, the SOS study, which I'm sure most of you will be familiar with, they followed up patients after gastric bypass, banding, vertebral band gastrectomy, and had a control group as well, to up to 26 years. And what they found is a higher risk of first-time major osteoporotic fracture in the gastric band group with a hazard ratio of 2.58. And what's very interesting here is that increase in fracture risk tend to happen at about year 3 onwards. So if you think about patients after row-wide gastric bypass, most of them by year 2 will have weight stability. They don't tend to lose any more weight. If anything, some of them will actually have a little bit weight regained. But what we can see here is a gradual increase in fracture risk over years, which possibly means there is more to it than just weight loss, contributing to the effect of negative effect of bariatric surgery on the bones. So this is a meta-analysis looking at fracture risk post-bariatric surgery. And here the authors found that the risk of any fracture was significantly higher in the surgery group, but about 29% compared to a control group. And the common fractures found was non-vertebral and upper limb fractures. So a bit different to your classic osteoporotic side fractures. So some of you wanted to recommend a sleeve gastrectomy rather than the row-wide. So I suppose the question here is the risk to bone health surgery type specific? i.e., is the sleeve better for the bone rather than just the row-wide gastric bypass? So in this study, participants were randomized to either wrong-wide gastric bypass or the sleeve. And what they found is there was more dropped in the BMD at the femoral neck, total hip, and the lumbar spine in the wrong-wide gastric bypass group compared to the sleeve. Both of them showed a drop, but it was more significant in the wrong-wide gastric bypass group. What about the bone turnover markers? Again, similar findings. There was more of an increase in P1NP and CTX in wrong-wide gastric bypass compared to the sleeve group. And this was despite, as you can see here, good level of vitamin D in both the groups. What about fracture risk? So in this large retrospective French study, they look at patients after various bariatric procedures, so wrong-wide, sleeve, lap banding, and BBG as well, and compared those to match obese controlled. They had a reasonable length of follow-up of 6 years data. And what they found is an increased risk of major osteoporotic fracture with RYGB only, hazard ratio of 1.7. And again, the fracture site, the raised forearm and the hip, so not really vertebral fractures. So it does seem that the sleeve seems to be better for bone health than wrong-wide gastric bypass. What about the last option? So quite a few of you went for to start this gentleman on IV zoledronate prior to surgery. So what's the evidence for that? Essentially, there's no evidence. So currently, we don't have any evidence for the efficacy of any other bone agent on preventing bone loss after bariatric surgery. What we do have is those 2 ongoing studies looking at zoledronate and denosumab, trying to see whether it does work in limiting bone loss of a bariatric surgery. So the results are awaited. But what I've found is this proof of concept study, very small study, but with interesting results. So in this study, the authors gave 1 dose of IV zoledronate to 4 postmenopausal women before going for RYGB. And they compared their urine, they compared their bone markers and also their BMD to 10 RYGB control patient. And what they found is there was definitely an attenuation in the rise of CTX and P1NP up to 6 months after surgery. So the triangle here represents the levels of the control group. However, despite these changes on the bone markers, it did not prevent bone loss after surgery. So there was still a drop in BMD at the total hip and the femoral neck, but not so much at the lumbar spine. Again, this is just 6 months data, but it does show that despite the positive effect on the bone markers, we are not really seeing a beneficial effect on the bone density. But this is a small study. So moving on to my second case. So this was a 73-year-old lady who underwent wrong-wide gastric bypass about 10 years ago. So at the time, her comorbidities were hypertension, OSA, arthritis, and high cholesterol. She had a BMI of 46.6 at the time. When she came to see us in clinic, her BMI was down to 29. So she'd lost essentially about 38% of her body weight, which is more of what you would expect of the wrong-wide gastric bypass. She had lots of risk factors for low bone mineral density, so I've displayed that there. But just to highlight, malnutrition was one of it. She lost a lot of weight. She had a family history of osteoporosis with hip fractures, and she was also on long-term lansoprazole use, which reduce your gastric acid, and that makes calcium absorption impaired. So the reason why she came to see us is because she sustained several vertebral fractures. And this was her biochemistry result at the time. So very raised urine NTX and P1NP, so bone turnover markers. She also had secondary hyperparathyroidism, which, as I said before, is very common in this population. So her DEXA scan at the time, a T-score of -4.8 at the spine and a T-score of -4.1 at the hip. So very severe osteoporosis. So at this point, how would you manage this lady, given that there's a general lack of evidence of the efficacy of any of this medication in the bariatric population? So would you go for oral alendronate, teriparatide, denosumab, or IV zoledronate? Okay, all right, let me just reveal the answers. Okay, again, quite a nice split. A lot of people want to start teriparatide, some zoledronate. Okay, all right, good. Okay, so what we did, because of a lack of evidence, we followed our NOC guidelines, which is the National Osteoporosis guideline in the UK that we tend to use, and also the NICE guidelines. And so this patient would be a candidate for teriparatide based on her vertebral fractures, a T-score of less than -4. She's obviously at very high refractory risk. So teriparatide is what we considered here. Now, teriparatide is a daily injection that you take for 2 years, and this lady did not want to do that, so declined teriparatide. For that reason, we chose the next best medication, which was denosumab for her. If she presented now, we would have also considered romosozumab, which is a monthly injection that you can have for a year that has as good or even better results than teriparatide. So what happened on denosumab? Well, these were her bone turnover markers before denosumab, so very much so elevated. And these are her turnover markers on denosumab. As you can see, quite significant reduction and suppression of those markers within the reference range. Did that translate to improved BMD? Yes, it did in her case. So that was 5 years of denosumab therapy. And her T-score at the lumbar spine was -2. Her T-score at the hip was -2.9. So huge improvement in her bone density on denosumab over 5 years. So what about guidelines to try to help us manage those patients who are high risk going for bariatric surgery? Well, in the UK, we have the British Obesity and Metabolic Surgery Society guidelines. We also have the American guidelines, which give a little bit more detail about how to manage these patients. And what I've done here is just summarize the main point related to bone health. So one of the main things is for the bariatric population, the vitamin D replacement, they need essentially higher dose of vitamin D as replacement. 2,000 to 400 units per day is what's been recommended. And that's really to try to aim for a target vitamin D of above 75 nanograms per liter. So most of us will tend to be happy with a vitamin D of above 50 in our patients in clinics, endocrine clinic. But in the bariatric population, both societies actually suggest to use a target for vitamin D of above 75. Also, more calcium has been recommended, so 1,200 to 1,500 milligrams a day. In our typical osteoporotic lady, postmenopausal lady, we would normally aim for 1 gram a day. And split doses is quite important to just help with absorption of the calcium. Both societies also actually advised on dietary calcium and calcium citrate as being preferred to calcium carbonate, as these forms of calcium are better absorbed by the gut, and they also lead to a lower risk of kidney stones. And we know that in bariatric patients, there is a slight increased risk of kidney stones. Now, in the UK, we don't have a prescribable form of calcium citrate, so we use a lot of calcium carbonate. But I know from my patient that you can buy it quite easily from Hollands and Barrett in the UK at £10 a bottle. Okay, so in terms of frequency of checks, so calcium and vitamin D checked is recommended at 3 and 6 months after surgery and then annually afterwards. So with regards to DEXA scan, there is not a lot of information from either guidelines as who would benefit from having a DEXA scan before and after surgery. There's a vague statement about DEXA scan after one-wire gastric bypass may be indicated at baseline and about 2 years after surgery. Both set of guidelines agree that IV zoledronate or parenteral treatment is preferred to oral biphosphonate, because of concern about absorption and also concern about ulceration of anastomosis in one-wire gastric bypass. So I personally think that most patients, if not all patients, should have a fracture risk assessment done using FRAX, for example. FRAX is very easy to use, simple and free to use as well. And especially in women who are postmenopausal and men above the age of 50 who are increased risk of fracture should definitely have that fracture risk assessment done. If you use FRAX without a BMD, that's the sort of output you would get, so displayed on the screen there. And it will help you determine who is at low risk, where you don't have to do much. If your patient fall in the yellow region. So obviously you want to measure BMD to further distinguish whether they are low risk or high risk. And in patients who are at high risk of fracture, you would want to do DEXA scan maybe at baseline and then 1 to 2 years after surgery. So coming to my summary points, so hopefully I've convinced you that the BMD, the bone microarchitecture and the bone turnover markers are all affected negatively by bariatric surgery. The fracture risk does go up. Anything from 20 to 70% has been described in the literature. Wrong-wide gastric bypass seems to have more of a fracture risk than sleeve gastrectomy. Lab banding, not so much. The use of osteoporotic agent for bariatric surgery is not evidence-based, but does seem to work, as I've shown in my patient here. IV Estrogen is recommended as a first choice or parenteral treatment over oral biphosphonate. Higher doses of vitamin D and high target level for bone health are required for bariatric patients. And I would recommend fraxing most patients going through bariatric surgery and to consider DEXA scan in patients who are high risk of fracture. Thank you very much for listening.
Thank you very much indeed. Really clear and practical points. We had some feedback last time where the audience wanted to skip the 5-minute break and use that to answer some more questions. So we shall do that. And for those who want to take a quick break, we're going to spend about 5 minutes on the questions posed by the audience here. So why are wrist fractures more common than typical osteoporotic fractures in this group? Do we know?
I think that's a very interesting question, and I don't think we know. Even in the obese population, the fracture that they are more at risk are very different to fractures that low BMI patients are at risk of anyway. So it's very interesting, but they are at increased risk of hip fractures, but not a vertebral fracture. And when you look at the BMD decline with bariatric surgery, you can see that the hip suffers the most as compared to the spine. So there's already some suggestion there as why they are increased risk of other fractures and not a vertebral fracture. But as to why they are increased risk of the ankle fracture, wrist fractures, or humeral fracture, I don't think anybody knows for sure.
So what would you say is the main cause of the osteoporosis? Because the effect of the gut hormones is pretty mixed.
It's very mixed. I think in the first 2 years where there's a very sharp decline in the BMD, that's probably more to do with the weight loss and nutrition, I would say. And maybe when you see more of a gradual decrease from 2 years onwards, it's maybe other components, that maybe the hormones. There's also leptin that goes down. You know, there's other things like estrogen and so on that changes after bariatric surgery. So maybe it's more hormonal afterwards. And in the first couple of years, maybe more driven by nutrition and weight loss, I would say.
Fantastic. The next question is, does high PTH worry you in a patient?
It does, because it suggests even if they have normal vitamin D levels or calcium level from blood, it suggests there may be, for example, a negative calcium balance. So maybe they need more calcium replacement. So I would definitely try to investigate a bit more what's going on.
And how would you justify teriparatide in a patient with raised PTH? If they already have high PTH?
This is a very good question, but here it's secondary hyperparathyroidism, so it is very different to your PTH, which is raised in your primary hyperparathyroidism, where teriparatide is contraindicated. So I would still, once they start on teriparatide, what we tend to do anyway is monitor the patients very closely. So they tend to have a check with the calcium and PTH at 3 months after you started, just as a safety measure. But I think in this case I presented, I think teriparatide was definitely indicated.
Fantastic. Thank you so much.